Dan, I'm really excited about today's episode. We've got Jerry Mansfield, good friend of class. We've worked with him for a while, haven't we?
Yeah, he's moved over. He's now the Chief Nursing Officer at Mount Carmel Health System, part of Trinity, and it'll be fun to hear his perspective. He always has something insightful to say.
Absolutely. Very passionate, someone that really cares about this topic. And we're going to get into the relationship between the patient and the clinician and how that can improve. And that's really a key part of all this.
Right. Well, let's jump right into this interview. It'll be fun.
Sounds good. We are very happy to welcome Jerry Mansfield to the Patient Voice Amplified podcast. Jerry, great to see you.
Good to see you too, Adam.
Thanks so much for joining us. And you were on the short list of people I knew we needed to have participate here. You've been a longtime friend of class, and it's always great to connect and hear what's going on with you.
I remember the first time you and I met at a HIMSS conference. I've always enjoyed our conversations and the relationship and the focus we've had on really patient engagement from that time. So I'm encouraged to just continue that with all of you. Thanks for including me.
Jerry, the feeling's very mutual. Thank you so much. We've enjoyed getting to know you over the years. You've been a longtime friend of class, and both in our research, and you've helped us with our patient engagement summits as well.
When you get involved in patient care, which I've been as a nurse for a lot of years, the initial times that you hear about engagement is really around patient satisfaction. And clearly the industry has transitioned a lot since the early 80s from satisfaction to experience. And I think really, I couldn't prove it, but I think our conversations were the first time I had ever got some traction with anyone around the concept of engagement, which I think is a really important term for how we will work with patients in the future. So this relationship and this conversation is extraordinarily important to me, and I think we're going to see it accelerate.
Yeah, I hope so. I agree with you. Dan and I conduct a lot of the research at class specific to patient engagement and so forth, and I think we both agree it needs more. Healthcare needs more answers, and so we appreciate the relationship and your insights. Jerry, can you talk a little bit about your background and your history and where you are today and your current role and how you got there?
So been a nurse since the early 80s. I was a diploma grad. I grew up in a small farm town community where nursing was not something that most men were thought about in terms of a profession, but I had some experiences in my early childhood that led to an interest in medical care overall. And no one in my family has ever been involved in the medical industry. So I had a hospitalization when I was a freshman in high school, and that's when I chose nursing. Fast forward, really just started in, direct patient care and acute care settings. My first job was at The Ohio State University in Columbus, Ohio. Orthopedics and prison unit, peripheral vascular, general surgery. Found my way into critical care, a couple other hospitals in that transition, but got a knack for leadership because I really wanted to impact the environment in which we delivered the care. Found my way to Medical University of South Carolina for 3.5 years. I was the executive chief nurse and chief patient experience officer. Very happy in my role and quite excited. And I think that's when really our relationship started to take off, because I was point person for patient experience at that location. And our CEO set a target for us to be at the top decile for patient experience in Press Ganey, likelihood to recommend. And we actually achieved it and sustained it. And so learned a lot in that experience, but always leaning towards patient engagement as the real true north. I will tell you that where that came from was my education and experience through my doctoral program in public health at Ohio State University, because it opened up an idea that how patients and families engage with healthcare providers to either incorporate or not interventions to keep them healthy or manage a chronic illness. It's very difficult work. And it's been quite a year, though, I will tell you, between COVID and economic unrest and social unrest and the attack on the U.S. Capitol. Starting a new job and a new organization in this past year and a half has been quite the challenge. But we have a great team, and we're really focused on back to our faith-based mission, which is serving the underserved, particularly in Columbus, Ohio, and excited to be thinking about our future.
It's interesting. You brought up just a second ago the trend towards more consumerism in healthcare. And that's something we've seen over this past year, especially during the pandemic, as telehealth ramped up and patients just became more empowered to make those decisions. What are some of the things you've done over the course of your career that really put the patient first through technology or through changes within an organization that really centered around the patient and that consumer aspect?
It started with the awareness, as I mentioned, with the doctoral program. My major was health behavior, health promotion. And we spent a lot of time really understanding the interface between a provider and a patient. It's that white space in between that makes a difference, whether the person does or does not follow perhaps a treatment plan. And more importantly, over time, we're realizing that all of our focus on disease-specific and medically driven decision-making is inadequate. When you involve patients and families in decision-making about programs and projects and healthcare services, their view is quite different than the provider. But when a health system and or a provider group is open to what the patient family wants and needs in their terms, it opens up a new conversation. So a very good example. When I was at the Medical University of South Carolina, I became aware that we had patient family advisory councils involved in decision making, really across 6 main domains of the hospital: adult, children's, psychiatry, et cetera. And what I learned in that facility compared to other experiences was everything, well, almost everything, but those councils were where we took a lot of initiatives to get feedback. And I'll tell you, you got to be brave to hear what they advise, because what you think from your medical and or provider mindset might be quite different than what they want to receive it. We had some really important lessons learned in those experiences, which led to a practice where we videotaped actual patients and families in their experiences of how they perceived us in healthcare. The university was quite involved in helping patients tell their story. And then we ultimately used those videotapes internally to reinforce messages to providers about when we talk about patient-centered care from the patient or family's perspective, what did that look like? And I will tell you, these were game changer videos, so much so that continues to expand, because we knew that to get across concepts of what's important to patients and families in the future, you got to hear it from them. And I will tell you, when we would play these videotapes, very targeted, obviously in groups or meetings, to watch the room change, it just changes the conversation. And frankly, both Adam and Dan, it reminds all of us in healthcare of why we chose this job in the first place, and reframes it to a sense of hope. The other thing that I want to talk about is efforts around creating frameworks and models that the patient is at the center, and then their interaction with all the other healthcare providers, they are the core. And to help folks understand that each of the providers within that interface, it's really the patient and family that ought to be guiding the majority of the conversation and the input. So it's not an inward focus, it's a patient to provider focus. And then the job of the team is to pull it all together. So you've got to deliberately think about making sure that the group that's involved in transitions around this topic understand that we've got to go to the passenger side of the car or the back seat and let the patient drive the decision.
Jerry, I love that. I love that you reconnect to your roots a little bit, is what I'm hearing. When you listen, you feel that sense of hope, you feel that sense of purpose reignited, perhaps for some. That really speaks to the value of truly engaging a patient, I feel, not just for their own benefit, but for the organization as well. So I really appreciate that you said that. One question that came up, I'm thinking about all these efforts to engage patients in their care, but I'm sure there's some that perhaps aren't ready to engage or willing to engage as much. What are your thoughts on that? I'm sure you got to do the best you can, but any strategies that you've thought through already that might help some of our listeners?
Really, I could think of many examples, but there's one that just, as you were talking, I just kept coming up. So I guess I got to share it. I'm in a meeting with a group of physicians and nurses about care of patients who have chronic wounds. So these are individuals that have had some sort of a lesion on their skin for a period of time that's non-healing, and we have to treat it. In this case, we were talking about diabetic neurotrophic ulcers. So these are patients that have a long-standing history of diabetes, and they have a wound on their foot as a result of the disease and the complications, and we're treating it. And in this meeting, one of the providers said, well, the patient is non-compliant. And I will never forget, one of our orthopedic providers said, let's talk about non-compliance. What does that mean? He said, first, let's start with the disease. If you are a long-standing diabetic, you can't feel your foot, you have altered smell, you probably have diabetic retinopathy, can't see your foot. So you can't feel it, you can't see it, and you can't smell it. What makes them non-compliant? And we all just sort of sat there. So it went from a label to, well, then how do we help that person see, feel, smell what they have on their foot while we treat it? And something simple. So in the treatment rooms, we would take a mirror and show the patient what their foot looked like, and then talk about, this has been caused by, you can't feel the pressure, you can't feel the need to wear the proper shoes and inspect your feet because you don't know it's there. And it's actually infected and shows signs and symptoms of infection. Odor, we can smell it, but you can't because of your condition. So it really opened up a whole new way of having an interaction with a patient and a family member in a treatment room. So what I'm getting at is that we categorize people, we have labels for people, and our job in the future is to understand that from where that patient is, we've got to transition from their perspective, what they're dealing with, so that we can help them incorporate a treatment option that fits within their budget, their home life, their experience, whatever. I'll give you another example. Going on a home visit to a post-procedure open heart surgery case. I walk into the house with a nurse practitioner. It's a home visit. And what do I see? It's a poor neighborhood. The patient is sitting in an upholstered recliner, feet up. She's got a big incision in the center of her chest. Daughter is making breakfast. What do we smell? Bacon and eggs. Post open heart surgery, right? And what I watched in that interaction with the nurse practitioner is acknowledging where they were, what was going on, and by the end of the visit, convincing the daughter, maybe we can transition some fresh fruit into diet tomorrow. Not cut out the eggs, cut out the bacon, just let's try fresh fruit. Then she also convinced the daughter and the patient that let's establish a goal over the next 7 days to get closer and closer to walking to the mailbox to get your mail. Because for the patient, that was how she connected with her family. So exercise and diet, both extraordinary. But what I learned in that experience again was I, as a provider, can sit there and tell you You got to change your diet. You got to exercise more. But what is that? But from within the lived experience, incrementally working on steps to a mailbox and introduction of more fruit into a meal were incremental steps that were more realistic for them.
Great example.
So think about that from a digital health perspective.
Yeah.
We've got the diagnosis, we've got the treatment plan, we've got all of her socio-demographics. We've just put in place some very targeted interventions, steps to a mailbox, and diet change. So then we follow up a week later. Are we or are we not making progress on those? Maybe she went from, I couldn't get out of my chair, to now I'm halfway down the driveway. Data. Now we're having grapes with breakfast 3 times a week. Data. Over time, little by little, with this patient, with this family, what's happening with her outcomes? Getting better, not getting better. But I think what we've got is then data, patient after patient after patient, family after family after family. If we can show that engaging patients and families in these decisions, making the progress in their terms with what they've got, makes a difference, game changer.
So Jerry, how are you tackling that with technology? Technology is supporting the acquisition of this data. How are you now mining it and making decisions based off of what you're seeing? And how are you engaging other technologies to help out?
We're not yet. So in my current role in our organization, we certainly have identified that digital health as an accessible way to connect with us is our first and foremost strategy. So actually Trinity Health is engaged in some pretty exciting things of how will we use data and data mining and artificial intelligence to change what we do. So they've developed new partnerships and have actually formed a new company to really begin to put some effort and money behind this opportunity. Because as Trinity exists, it's 92 hospitals, 22 states, not just hospitals, but skilled nursing facilities, rehab facilities, psychiatry, et cetera. We have an opportunity to really learn. And it's national. So we got East Coast, West Coast, North, South. So I'm excited about the future because I think we know it's an issue. B, we want to make it better. And frankly, one of our key tactics is for patients and families, we have 3 main goals for the organization: partner, listen, make it easy. And if we can make that happen for a patient and family, partner, make it easy, and listen, again, I think it's important. So I'll give you another example. We at Mount Carmel created a digital app that we thought would improve our access of patients and families through their smart device. So we were pretty proud of it. Took it to patients and families. You know what they said? Looks like you took your website and put it on an app. It's not that helpful. So we have to go back to the drawing board, right? So again, that sort of reinforces what we were talking about earlier. Smart, well-intended people want to do the right thing for patients and families, and then the patient-family voice is like, not so much. But that interface and that interaction will make it better.
So with that, what advice would you give other providers about being more patient-centric? I think what you shared on the app is a great example. Anything you'd add to that?
Go, see, and listen. And over, if we just step back, take a deep breath, and listen to what the patients and families are saying, that will give us insight to how we take the next step. We're very transactional based in healthcare. We're motivated by more visits, more patients. That's how, in many cases, we're remunerated for our work, but that's going to be insufficient for the future. So I would encourage providers to first do more listening, do more observing, and then create environments where providers and patients and families working together can create more innovative solutions on how to do it different. I think there's some extraordinary work that's happening. I had a wonderful opportunity to hear a webinar. It was a few weeks ago I happen to be a board member of the Friends of the National Institutes for Nursing Research, and we support efforts of the National Institute for Nursing Research in DC. We have a new person at the helm that was just hired, Dr. Shannon Zank, who's really trying to do several things, of course, in terms of research at the nursing and more national level, is to create awareness around the importance of interprofessional research and really beginning to tackle differently social determinants of health. So she, in one of her inaugural moves, had a presentation by a gentleman from Duke University that talked about the science around using data to drive care through digital methods with patients and families. There was study after study after study that just showed the difference between what data we collect and the decisions we have to make. And it was extraordinary. So what it's teaching me is that, again, we have a lot of great ideas of what this might do, but the devil is in the details to try to figure out when those two things meet to try to do the right thing for patients and families. I'm going to share one example of where I sort of really saw this come to light. I was in Medical University of South Carolina, and I was just trying to find out, what we're doing in terms of patient engagement beyond the health system. And we had a pretty robust, well, it was not just pretty, it's huge, second federally funded and state funded telehealth program in the US. So they said, you got to watch Kelly Garber. So I set up this appointment and I go across the street, and it's in this old Charleston home, probably should have been torn down, but it had been converted to the telehealth offices. And Kelly is going to conduct a school nurse visit in a rural county about 2.5 hours from Charleston. So she turns on her computer, she initiates this phone call, a school nurse answers the call, and they talk about a student. So I'm watching this at her desk in Charleston for a student that's 2.5 hours away. She diagnoses through this interactional visit an ear infection by using a tympanic visual that the school nurse inserted, but what Kelly saw on her screen, easily, based on the symptomatology, diagnosis, an ear infection, enters orders. The prescription is sent immediately, because the family has already permitted this, sends the prescription to the family's closest pharmacy, that when mom and dad leave work, they can pick up the prescription, student gets treated. All of this happens within about 7 minutes. Can you imagine? If we could do that over and over and over, nobody had to leave school, nobody had to leave work, kid gets diagnosed and treated within a 7-minute time frame. It's extraordinary. If we can't just see the future of that, I mean, shame on us. So I think what COVID-19 has taught us is that when it forced people to not seek care and stay at home, those who took advantage of telehealth services realized something that maybe they had not experienced before. And now we need to take our learnings and leverage it for a new future.
Just curious, how long ago was that story, the student and the telehealth? It sounds like it was before the pandemic.
Yeah, about 2 years, I would say.
Okay.
2 to 3, maybe.
So interesting. Yeah, and we would agree the light got turned on because of the pandemic on telehealth. We've heard story after story, haven't we?
Yeah.
Well, and to that point, Adam, I mean, if we can do it during a pandemic, why wouldn't we do it all the time? Right. And then we get into conversations about, well, maybe it's not funded. Why? Why would it not be funded? And if we can do it during a pandemic for certain conditions, what might we do for many more chronic illnesses? And we know that there are a lot of health systems out there doing great home monitoring programs around diabetes, congestive heart failure, respiratory conditions, COPD, pneumonia. I mean, we can do this better outside the four walls of a health system, and we can do it much more economically. And think of the other effects. They're not getting admitted. They're not staying. They're not going to develop some hospital-acquired condition that they didn't expect when they got there. I mean, it's such a better option, and it's in their home or where they can access it. I mean, it's just such a cool future. So I think more and more we're just going to see more technology-enabled healthcare delivery. And frankly, in the end, we're all going to be better off because of it.
That's great. Jerry, this is fantastic. It's so good to catch up with you and hear your perspective. Your excitement just comes right through, and all your stories and your passion and being willing to go visit patients at their homes. I love that story. We appreciate you sharing that. Any parting words, any other thoughts related to everything we've talked about today?
Parting words. You know, Adam and Dan, I've been in healthcare a long time, and I've seen just tremendous change in my short career. Even though it's been long, it really in life, it's been short. But, when I started in nursing, people with joint replacements, hip or knee replacements, orthopedics would stay 7 to 14 days. I just visited one of our hospitals yesterday. From the time a hip or knee patient enters the operating room before they go home, less than 10 hours.
Wow.
Usually around 6 to 8. So our science is extraordinary. And yet, I think another parting word is, if anything has taught us this last year, it's still rough out there. There are many constituencies, if you will, that want to put up concerns or barriers about science in healthcare. Most recently, I'm thinking about vaccines. But I look people and friends in the eye that tell me COVID-19 is not real, that it's fake, that it's all political, and those are tough. Those are tough struggles. So I think we're all living in a time of some great transitions. It's just my parting hope is that I know one day I'm going to be laying in a hospital somewhere getting treatment myself. And I want to be able to look up into the eye of the provider and say, I've worked to help create environments where now I am the recipient and I'm going to get what I envisioned could be. So that's what gets me up in the morning anyway. Hope.
That's great, Jerry. Thank you so much. I'm going to take away from this conversation the concept: we've got to partner, we've got to listen, we've got to make it easy. I think you've summarized that so well. Really great stuff. So yeah. Always good to see you. Thanks a million. We love your perspective and your leadership, and wish you the very best. We're here to support you any way we can. And thanks again. This was great.
You are so welcome, and I appreciate you guys' time and also keeping the conversation going. I think you all have facilitated a greater level of awareness around this, particularly when we've had those summits with the vendors. My experience with those vendors, it's changing. I think they're getting a different perspective, and I think classes played a big part in making that happen. So my hat's off to all of you, and I hope we'll stay in touch as the years go on.
Certainly. Yeah. Thank you again. Thank you, Jerry.
All right, gentlemen. Thanks so much.
Thanks.
Well, Adam, that was fun to talk to Jerry and hear his perspective on the interaction between the patient and the provider. Can you tell me anything that stuck out to you in that interview or anything that caught your ear?
He said something I hadn't thought of before. I really liked when he said the interface between provider and patients, the white space in between that relationship makes a difference whether the patient does or does not follow a treatment plan. It's such an interesting concept. There's a time and space where we're not in front of the clinician, we're not in a care setting, and that's really maybe where the rubber hits the road, and healthcare can improve right then. So yeah, what did you think of that?
I think we've all experienced this a little bit for ourselves. When you leave that doctor's office, sometimes you're left with great discharge instructions and a clear plan of what to do. And other times you're left wondering a little bit. Every time you get a little sniffle or a little ache or pain, you're not quite sure what to do with it. And I think that's a great opportunity for technology vendors to step up, for providers to implement some technologies that help guide the patient through that process when they're in that so-called white space, whether it's care journeys that follow them for the type of procedure that they've just had, or post-visit communications and reminders and follow-up, or remote patient monitoring at home that helps them feel a little bit of peace of mind as their doctor is is seeing their vitals and knowing that they're being taken care of.
I think of family care journeys that I've been a part of or seen, and so much happens outside of the purview of the clinician. You know, scheduling appointments, requesting prescription refills, organizing medicine, just all of those pieces that happen outside. So I love that Jerry has thought about that. He's promoting that. It gave us some really great insights. Well, Dan, let's go to our research minute. We always want to share a couple things about what we're working on currently. What's something you've worked on this week that you want to share?
You know, we're in the middle of a couple of patient engagement focused studies right now, and I was talking to an organization about telehealth this week. And it was really interesting. Sometimes we like to pigeonhole organizations into what telehealth should be or how we've historically thought of virtual care. But this organization, it was a smaller practice up in the Northeast that had a predominantly elderly patient base. And these elderly folks couldn't wait for the vaccines to roll out so they could start to do their meetings in person. So it's caused a decline in their telehealth usage. But I thought it was interesting, they have a physician that's immunocompromised and doesn't want to come into the office yet. So the way they're leveraging their telehealth solution is they're having the patient come into the office and they do their registration and check-in process, and then they give them an iPad in the room to talk to the physician who's at home. Wow. I thought that was a really unique application of telehealth technology.
Oh, that's great. Wow, I haven't heard that one before. I like that.
Yeah, that definitely is a unique telehealth situation that I thought was just fascinating. So Adam, why don't you share with us something that you've overheard at class recently?
I had an amazing call this week, and I was working from home. I ran out to tell my wife about it. I was so excited, and then I came and found you and said, Dan, you got to hear this. You and I have talked about open scheduling, how it's such a priority for patients, but it's not commonly found, right? A lot of clinicians don't want to open up their schedules. We told the story about an organization that accidentally opened it and everything was fine. Right. Well, I talked to an organization this week that requires their clinicians to open it up. They didn't open it up 24/7, but they have at least a couple appointments every day that are open so patients can go in and select a convenient time. First time I've heard that.
Well, Adam, that's interesting. What has that done at this organization to affect the patient experience?
They talked about how their Press Ganey scores have increased because of that. So you've got happy patients. They're rating the physicians higher because they have access to the schedule. So really revolutionary, if you ask me. Hardly any other organizations we've talked to are doing that. So really a fantastic finding.
Well, fun. It's always interesting to hear some of these stories from our research conversations, and it's fun to talk to those provider organizations. Well, Adam, I know you like to end these episodes with a quote that you've come across. Who do you have to share with us today?
Okay, so there's this obscure person named Jeff Bezos, I think you've heard of. Founder.
Only one of the richest men in the world.
Yes, we know who this is. It's a quote about being customer focused, and I want us to think of it as being patient focused. He said, if you're competitor focused, you have to wait until there is a competitor doing something. Being customer focused, insert patient focused here, being patient focused allows you to be more pioneering. And would absolutely agree with that. That is the greenfield in healthcare. Let's focus on our patients more and take care of them.
That certainly sounds like the organization you were just talking about, looking at being patient focused rather than competitor focused, and they're making a difference for their patients.
Yeah, absolutely. All right. Well, we want to thank our listeners for joining us again for our podcast, and we have more to come. So tune in next time.